Good morning to all. I am Paresh Prabhugaonkar from Pharmafer. On behalf of Pharmafer, I welcome all the eminent faculty and distinguished delegates who have gathered here virtually for this live webinar on rare bleeding disorders. I extend my warm welcome to Dr. Flora Peyvandi, who has been kind enough to spare her valuable time with us today. I also welcome Professor Dr. B Agarwal. Sir needs no introduction. He is an institution in himself, and I further request Professor Dr. B Agarwal to take up the session ahead. Thank you all.
Thank you, Paresh. I'll just share my screen.
Good morning.
Good morning.
Good morning.
Good morning,
everyone.
Good morning. So good morning to one and all. Our guest speaker today is Professor Dr. Flora Peyvandi from Milan, Italy. She'll be speaking to us on rare bleeding disorders. This webinar is brought to you by Mumbai Hematology Group. It is supported by Pharmafer and managed by Mice Ideas. I thank Paresh and his team from Pharmafer, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our chief guest Professor Jasmina Ahluwalia from PGI Chandigarh, our guest speaker Professor Dr. Flora Peyvandi from Milan, Italy, all our discussants who are themselves eminent hematologists from India, and you participants for sparing your Sunday. Must remind you that right starting from tomorrow for the whole week, we have the update in lymphoma, which includes the best of 16th ICML, the International Conference on Malignant Lymphoma, which was held in Lugano 2 months ago. This whole week, we will be busy with these lymphoma updates, Monday to Sunday, and the timing is 5:45 p.m. to 9 p.m. So 13th to 19th of September. And thanks to all of you for registering in huge number. We have 1,200 registrations across the globe. It's my pleasure to introduce Professor Dr. Flora Peyvandi now. She is Professor of Internal Medicine at the University of Milan and the Director of the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center. She received her medical degree from the University of Milan. She is certified in hematology and was awarded PhDs from the Maastricht University, the Netherlands, and the University of Milan for research in the field of rare bleeding disorders. Her basic and medical science research has focused on the investigations of coagulation disorders. Her research in the prevalence and mechanism of coagulation disorders aims at developing cost-effective treatment for treating patients worldwide. She has authored or co-authored over 310 scientific publications that have been published across well-known specialized journals. She's also written 18 chapters in various books. Since 1999, she has been invited as an expert speaker to over 100 national and international meetings and congresses. She is recipient of over 40 project grants funded by Italian and international organizations. She was the principal investigator of the establishment of a European network of rare bleeding disorders program. She participates and she has been a participant in clinical, educational, and research activities in different parts of the world. She was chair of the ISTH Scientific and Standardization Committee on Factor 8, Factor 9, and rare coagulation disorders. She is member of the ISTH Council, member of the Executive Committee of the World Federation of Hemophilia, member of the Executive Committee of the European Association for Hemophilia and Allied Disorders, member of the Medical Advisory Group of the European Hemophilia Consortium. In 2014, she was awarded the Great Hippocrates, which is given to Italian Medical Researcher of the Year. Now coming to the discussants this morning, we have Dr. Srimati Shetty, former scientist F, Deputy Director, Senior Grade, Department of Hemostasis and Thrombosis from National Institute of Immunohematology, ICMR KM Hospital Campus, Mumbai. Dr. Jina Bhattacharya, DM Clinical Hematology from AIMS and now Professor, Department of Clinical Hematology, Guwahati Medical College and Hospital, Guwahati. Colonel Dr. Sanjeevan Sharma, Consultant Hematologist, Professor and Head, Medical Division, Command Hospital, Lucknow. Professor Aleem Jan, Hematologist and Hemato-Oncologist at Mubarak Group of Hospitals, Srinagar, J&K. Dr. Chandrakala S., Professor, Department of Clinical Hematology, KM Hospital, Parel, Mumbai. Dr. Satish Kumar A., Hematologist, Hemato-Oncologist from Columbia Asia Referral Hospital at Bangalore. And Dr. Gunjan Prasad from the Department of Clinical Hematology and Bone Marrow Transplant, Apollo Hospital, Kolkata. We now have the Sunday quiz for the postgraduates. Today's quiz is related to oral azacitidine. You will be given 9 statements about oral azacitidine. Out of these, 8 are correct, 1 is wrong. You have to pick up the wrong statement and email the number of that wrong statement to mbagarwal1@gmail.com. Winner will be fastest finger first. So at the top you see the email ID on which you will forward one of these numbers of the statement which is wrong. And now I tell you the 9 statements about oral azacitidine. 1. Until recently, maintenance therapy for acute myeloblastic leukemia was not the standard of care. 2. Maintenance therapy using oral azacitidine, CC486, was researched in transplant ineligible elderly AML in first remission. This trial was called PAUSER AML 001. Statement 3. Oral azacitidine CC486 was given as 300 milligram tablet once daily for 14 days per 28 days cycle. Statement number 4. The results showed improved overall survival, 24.7 months versus control group receiving placebo, 14.8 months. Number 5. The results also showed improved RFS, relapse-free survival, of 10.2 months in the azacitidine group versus 4.8 months in the placebo group. Statement 6. The adverse effects included GI symptoms, neutropenia, and thrombocytopenia of different grades. Statement 7. This study led to the approval by US FDA of oral azacitidine for transplant ineligible elderly AML in first remission. Statement 8. Subsequently, oral azacitidine received US FDA approval for high-risk MDS and for post-transplant maintenance therapy in AML. And the last statement, number 9, is oral azacitidine is available as 300 milligram tablet under the brand name Tab Onurec. You have to forward the number of a wrong statement to the email ID put at the top. 8 statements are correct, 1 is wrong. So the email for the number of the false statement to mbagarwal1@gmail.com. Now it's my pleasure to introduce our chief guest of the day, and that's none other than Professor Jasmina Ahluwalia from PGI Chandigarh. Everyone in India knows her. Her contribution to the field of hemostasis and thrombosis has been immense, and all of us have learned a lot from her during last 3 decades in this field. Professor Ahluwalia is Professor of Hematology at the PGI Chandigarh. She received her medical degree from the AFMC Pune. She served as a medical officer in the army for 5 years. After that, she did her MD pathology from PGI Chandigarh. She stayed on to join the Department of Hematology, PGI, and became a faculty from 2000 onwards. She has continued to work in the coagulation lab since then. She has over 150 publications to her name. Her interests are in the lab diagnosis and workup of patients with bleeding and thrombosis. My pleasure to invite Professor Jasmina Ahluwalia to inaugurate this webinar and give us some words of wisdom. Thank you.
Thank you, Dr. Agarwal. It's a wonderful opportunity to be here today and speaking to and listening to a very good webinar which is waiting for us. And of course, speaking to so many people interested in hematology. Dr. Agarwal's letter to me, email to me said that there have to be 3 or 5 minutes of something to inspire people in a career in hematology. And that got me thinking as to why and how I eventually reached hematology. So I don't know about the others, but I'd like to share a little bit of what I went through till I reached this place. So like any other Indian student till class 10, the decision was very clear. I couldn't do history and I couldn't learn up geography. So it had to be a career in sciences. And I discovered I wasn't really very good at numbers either. So that took physics and chemistry out of range and I had to opt for biology. In class 11, I was really lucky to have a very inspiring biology teacher. And she taught me one of the greatest lessons which has stayed with me all these years. She said that for anything that you need to know, remember, learn, just ask yourself who, what, when, where, why. And if you can get the answers to this, you will be able to answer anything. I must say I've used this in my exams as well. And I'm sure people who are listening, the young students, they could also keep this in mind that whenever you're tackling anything in any subject, these 5 questions need to be answered. After that, I joined MBBS in one of the prestigious colleges of the country, the Armed Forces Medical College, truly one of the most memorable years of my life. And there again, it was a teacher who took me on to pathology. Our professor of pathology was a person, I think, who lived, breathed kidney. He was always thinking about what was new in kidney disorders. And that thing was always very obvious to all of us students who watched him. He was very inspiring. After that, I was fortunate enough to reach the Postgraduate Institute of Medical Education and Research, where I stay till date. And I was very fortunate to come across a real good panel of teachers here. So now the decision became tough. Which way to head? Was it histopathology? Would it be hematology, cytopathology? But again, it was our teachers, I think, who showed us what a wonderful subject hematology was. And what was very, very inspiring then was that it was a very easygoing department. There was learning and there was an ease and comfort for anybody who wanted to work there. So that sort of took care of my joining hematology. Once I joined the department, at that time, there was suddenly a vacancy in the coagulation lab. And I was told to work there. It looked very daunting at that time because as pathologists, we wanted to do morphology, we wanted to do molecular state of. But I think my circle of fate caught up with me and I was running away from numbers and I landed into a coagulation lab where everything is numbers. But no regrets. It's been a really nice learning lesson. You get to play Sherlock Holmes all the time. There's a new case, there's a new test that throws you off balance. You go looking for answers and you feel very rewarded when you reach the correct answer. Hematology today has a lot of choice. Those of us who want to do clinical hematology, this country is so vast and we have so many diseases that you're going to see even the rarest at some time if you opt for it. If you're somebody who likes challenges in the clinical field, that is waiting for you too, because we have to have treatment at very cheap costs. So you have a challenge in front of you, all of those who want to do clinical hematology, that you can think of new ways of reaching your patients at cheaper costs. For those of us who love the lab, well, if you like morphology, you have malignant hematology, you have hemolytic anemias. If DNA is what gets you going, then there are, as of now, all of our hematology practice is based around molecular testing. So that's where you can head. And if it's research that fascinates you, or if you join medicine because you thought you would do research, then there is no end. For the clinical people, the drugs are now getting tailored in such a way that I think very soon we will be there that for one person, there will be one drug. And for the lab people, We started with tissues, then we went to cells, then we went to genomes, proteomes, and I don't know where we will end. So then the world, there are no boundaries, and it's just limitless what we can do. And we're really spoiled for choice now in hematology if we want to do something. I would like to say only one thing as I finish. If you love hematology, let it show. Who knows, you might be able to inspire somebody to take this up as a career. I'm always and eternally grateful to my teachers because they showed me what a lovely life was waiting for me. And no matter where you are, if you're in the clinics, you're in the labs, you're in the research lab, let everybody know you love this subject. I'd like to end by thanking Dr. B Agarwal for giving me this wonderful opportunity to be, listening to Dr. Flora Peyvandi today. I think I've had very few opportunities to listen to her, but each time has been a revelation. Her dedication to rare bleeding disorders, which most of us don't tend to see very frequently, is remarkable. And her work is so important because whenever we are stuck in the labs, we go back to these important references to help us out. So with that, I'd like to thank Dr. Agarwal again and wish you a very happy webinar today. Thank you.
Thank you, Professor Jasmina, for those very kind words and describing the journey of your life. This has been really inspiring. And thanks for everything, and thanks for sparing us Sunday morning to be with us. And now it's over to Professor Flora for her lecture. You're welcome.
Good morning to everyone, and thanks very much for your really very, very kind words. Professor Agarwal, for organizing this meeting, which is the second time I'm participating. I have to say, as I always say, I miss India, and I hope that we can have the meeting, face-to-face meeting, seeing each other. And in upfront, I want to thank all the doctors in this really difficult time of COVID, helping the patient and organizing yourself. And for your actually beautiful words, really, you made the emotion in me for when I started the rare bleeding disorder in Middle East area, when I see a flag in a country where the number of the patient affected with rare bleeding disorder were higher than hemophilia. And I remember Professor Manucci was standing close to me and said, here it is. This is the word that you have to work on it, and you have to start the rare bleeding disorder because this is a area that there are not so many people are working, and your PhD should start with that. And that was it. So what I'm reporting today is just a summary of what I could do in this last, I would say, 25 years of my life on rare bleeding disorder. So now I try to share, but I see that it's not allowing me to share my slides. Is there any person that could help me why my slides are not?
Yeah, Dr. Flora, you have rights to share. Just open the presentation. You open.
No, I'm there, but I don't know for which reason it doesn't read my slides.
Yeah, now you can try them. Okay.
Could you see them?
Still not, ma'am.
Okay, because I cannot also.
As you told that you open the presentation first, right?
Yeah, it's already opened,
Yeah,
and it's usually the way that I'm doing, but.
Yeah. Now go to Zoom and just share, and just click on that window where you open the presentation, and then it will come on the share screen.
Yeah, that's the way usually I do, but the point, as I was saying, is I'm Mac. I don't know if that's a problem with a Mac.
It might be I think, ma'am, it is a Mac issue or something.
Because my presentation is open and I'm on the division, but cannot see any of my slides on your desk.
Okay.
So how we can solve that? I'm sorry for this.
You can do one thing. I'll just do one thing. I'll just in the chat box, I'll just share my email ID, and I'll definitely run from my end, and just you can say while changing the slide next, I'll proceed the slides. It will do.
Sorry, I didn't catch what you said. Sorry.
What I'm telling, I'm just posting my email ID in the chat box. You can mail it the presentation to that mail ID, and I'll share the screen from my.
Okay.
Yeah.
Let me to try again and to see what is happening. It's really amazing. This has never happened.
You can see just I've shared in the chat box my mail ID.
Okay. I'm really sorry. I know that the time is limited and
No problem, madam. Just you can email your presentation and then he will play it for you.
And next slide, please. So the rare diseases, usually they are affecting 5 people for 10,000 of the general population. However, I think every region of the world should indicate what is the correct number. And usually we have the underestimation because we do not have a good diagnosis, especially in the rare disorder, where there are lots of problems in the labs to make the correct diagnosis. And however, the number of these patients are rare, they need a high quality of care and also a good organization. I remember when I had a presentation in Saudi Arabia. I went back to look what is the situation over there in one of the Middle East country with a high rate of consanguinity. And I seen that there are about 8,000 type of rare disorders. And of those, 75% are affecting the children. 30% of the patients die before their 5th birthday, and 80% of the rare diseases have identifiable genetic origin. And again, I think it's very important in every country to come up with a national registry and making a best map of the country in terms of the affected patients. The next one, please. Here is the rare disorder in terms of hemostasis. Hemophilia A and B have the same incidence, which are X-linked disorder with 1 in 5,000 for hemophilia A and 30,000 for hemophilia B. And the von Willebrand disease could be very frequent as an allele frequency. However, the affected patients, they are severe cases like type 3 are about 1 in 1 million of the general population. The rare disorder that I'm mentioning today are ranging from 1 in 500,000 for factor 7 deficiency, which is more frequent, up to those cases, for example, for factor 13 deficiency, which is much less rare. But for example, in India, I think the cases of factor 13 deficiency is much higher compared to the other parts. And that is something we can probably discuss in the discussion. Next slide. Here you can see one of the 2019 annual global survey, which looked on the numbers reported by every region of the world. And of those, you can see that 48% of the patients, they were having factor 8 deficiency with hemophilia A and 10% of hemophilia B. And it's interesting to see that rare bleeding disorder are about 1/3 of millions, 300,000 and 9%. So that numbers are very much close to the number of hemophilia B. However, if you look for the facility in terms of diagnosis and especially for the treatment are not really at the same position. So that's the reason why more attention is required in this field. Next, please. And here you can see within the rare bleeding disorders, factor 7 and factor 11 deficiency seems to be the most frequent, at least in the European country. And again, if you move from one region of the world and to the other, in terms of also the small villages where the consanguinity could be higher, the numbers could jump from some of the region. For example, we have seen some area between Iran and Afghanistan. There is a large number of families with factor 13 deficiency, and also the numbers of factor 10 deficiency could be high and associated with the severe bleeding and especially GI bleeding that we're going to see later. Next one, please. So what about clinical manifestation? Once you make the identifying the patient, you have to understand how to make the diagnosis and treatment of these people. And how is the bleeding tendency? The bleeding tendency of this patient could differ really very much from one patient to the other one, and even from brothers and sisters. But the most typical symptom are mucosal type of bleeding, and usually they are less severe than hemophilia. In some of the patients, you can just understand that they are affected when they go through the surgeries. And for the women, for example, during the delivery, and in those regions where circumcision is customarily used, it could be in the male boys the first symptom. and sometimes could be really associated with a high mortality because the physician do not know that these patients are affected with any clotting disorders. But what about the more severe type of bleeding, like cerebral bleeding, umbilical cord bleeding in a very early stage of the life, hematolosis and hematoma that could really link to the poor quality of life of this patient, and GI bleeding? These kind of bleeding are usually present in fibrinogen, factor 7, 10, and 13 deficiency. As I said, in factor 10 deficiency, what I saw, it was usually a high rate of GI bleeding and sometimes hematolosis and hematoma. In 7 deficiency, CNS bleeding, and sometimes could be also hematolosis and hematoma. In the women, spontaneous abortions is very frequent in afibrinogenemia and factor 13 deficiency, and they require particular attention during the pregnancy and delivery. Next one, please. So in women life, there was not really so much attention in how is the quality of this life. The women affected with rare bleeding disorder, they are having terrible life because in every stage, when they start the first menstrual bleeding and every month with the menorrhagia, and then during the pregnancy and delivery, and even after the delivery, postpartum. So in every step of their life, they could have severe hemorrhagia, and this could be associated with anemia and iron deficiency. And if it's not diagnosed well and cured as it has to, that could be associated with the poor quality of life of these women. So particular attention, I think, should be done to the women. Next one. So the most common symptom in these women, as I said, is actually menorrhagia. And this menorrhagia has been reported very heterogeneously in a literature. In some of the studies, we can see 10% of women, and some of them up to 60, 70% of the women. So I think we do need to have a good study in the women affected with each single type of deficiency. And the numbers, since they are not too many, as we discussed before, each of us, we are seeing few patients. But it would be nice to have a register in a country to understand really with a gynecologist, what is the rate of the bleeding in these women and what type of a strategy in terms of health system we should do for these women. And as I said, please take attention, make the examination in terms of anemia and low level of iron, and because that's an easy treatment to do. And with that one, you can improve the life of these women and the start of the life in terms of work, sport, and every type of the facility that they could have in their daily life. Next one. Here is how we have to start the diagnosis of these women. And some of these women, they are ending to the gynecologist and they start with a normal pelvic evaluation and hormonal evaluation. But usually is I would say not enough education to the gynecologist how they have to make an examination of hemostasis alteration. And that's a work that that we have to do as a hematologist, and we have to really be in collaboration and teaching them how a woman with menorrhagia, a part of all pelvic examination, do and go through the diagnostic chart for any type of clotting disorder. Next one. So for the pregnancy and delivery, what we can do? We can see from this table that during the pregnancy, some of the factors like factor 7, 8, 10 von Willebrand and fibrinogen could increase. And maybe during the pregnancy, they are not a big issue. However, you have always to measure and to be sure that the levels are more than 30% at least. But some of the factors, they are not increasing, and you do need to treat these patients and pay attention, especially in the first 3 months, for prevention and eventually avoiding the abortion and high rate of the abortion in these women, and even during the pregnancy and the last 3 months and after the delivery. Next one. So how we have to move on in our country, and if as a hematologist we want to make a plan, what we have to do. I think we should start to think about how I'm going to improve the diagnosis, and the association between the laboratory phenotype and clinical severity was the main work that I did in the last 25 years with my group, and trying also to understand how I have to treat this patient and what I have available in my country in terms of acute bleeding treatment and prophylaxis for prevention. And how is convenient to make the prophylaxis, and whether we have to do it, and in which portion of the patient we have to do it. And in women or girls with bleeding disorder, how I have to behave. Next one. As diagnosis, I think all of us, we are fortunately very familiar with what is happening with hemostasis. Next one. Next slide, please. We can just say that both tests, PT and APTT, are usually sensitive enough to detect abnormal clotting factor activity. Of course, very small amount of deficiency, we might miss it with this type of assay, but the important deficiency, we can find it for fibrinogen factor 2, 5, 5 and 8, 7, 10, and 11. However, for fibrinogen deficiency, probably there are more specific assay. First, we can start with thrombin time, and then we can move to the Klaus method, which is more specific. And then I think what is important to keep in mind that for factor 13 deficiency, of course, these assays are not enough. So if you see the prolongation for the younger physician in the board that are listening to us, so you have to be able to interpret the data as a hematologist, because lots of doctors, they are sending the examination, but they are not making interpretation. They are finding some kind of prolongation of PT and APT, but you immediately have to go with a mixing study. And if there is correction, that's a sign of factor deficiency. And if there is no correction, there is a presence of inhibitor. And if there is a correction, you should go with a specific type of assay, talk with the people in the lab, and trying to come up with the next slide with a specific type of assays for every type of deficiency. Next slide, please. So as I said before, some of the assays are like APTT, suitable for factor 11 deficiency, and PT-based assay for factor 2, 5, 10, and 7 deficiency. For fibrinogen assay, please use the Klaus method. However, maybe is not really sensitive, because lower than 50 milligrams sometimes is a trouble to have a very accurate data, but you definitely need to have antigen and activity level, because that's very important for the management of the patient. For factor 13 assays, we usually use the Klaus solubility assay, but this assay is not anymore recommended in Europe anymore, because they are poorly standardized, and you can use it only in the emergency when there is a severe deficiency, but it's not quantitative, and you cannot really know if there is a levels of factor 13 over 2-3%, and that assay is not really enough. And for factor 2 and factor 1 deficiency, fibrinogen, as I said, is not only enough to have the activity assay, but you need to have the antigen. And why that is important? Because if you have the enough amount of protein, but they are not functionally active, that you have to pay attention when you are treating your patient, because that might end up with a thrombosis. And that's the reason why a clear picture of afibrinogenemia or aprothrombemia is different from dysprothrombinemia or from the quantitative deficiency of fibrinogen. That you have to keep in mind, please. Next slide. What about the molecular diagnosis? Lots has been done, and as we heard also before, the field of hematology is changing in oncohematology, but also in hemostasis. When I was a PhD student, we were going only with the PCR and making the sequencing, and there were clear picture of what were the gene that we had to analyze, and some of the genes has been discovered in the last 20 years. So now there are 3 classes of genes that you have to keep in mind. For example, for factor 1, afibrinogenemia, factor 2, 5, 7, 10, 11, and 13, you have to look for the genes that are encoding that specific type of protein. But if you have factor 5 and 8 deficiency, the genes of factor 5 and 8, they are working very well. The problem is a pathway secretion. So that means there are 2 genes, MCFD2 or LMAN1 are the most frequent one that are associated with the secretion pathway. And if you have the vitamin K dependent factor with a combined deficiency of 2, 7, 9, and 10, and protein C and S, all these proteins by themselves, they are produced normally, but the problem is a post-translational modification of vitamin K, and that's the reason why you should look for the 2 genes of GGCX and VKORC1. Next slide is just showing in the next 2 slides, I think I'm just showing how from the PCR and Sanger sequencing, which are the gold standard for the small genes, when we know exactly which is the area of the gene, the chromosome and the specific genes, and we have the family history, we can go specifically for that. But if that's is not clear and we have some of the hemostasis disorder and we do not know exactly what is the defect, next slide is just showing you how things has been changed, and we have the new techniques like exome analysis or even genome analysis, which are less cost effective but less time consuming, but you need to have a very good team of bioinformaticians that they are going to put the data together. And of course, you need to have the family members that are affected with a similar type of defect. And next slide is showing that the next genes really opened a big world of genetic analysis, and the searching the identified variants in the disease-related databases like human genome mutation database and coagulation factor variant databases and ClinVar is just allowing us to understand what are the genes responsible for a specific type of phenotype that we're going to find. And also the availability of the genome AD and 1,000 genome sequencing with the big data, we can look on the genotype frequency and geographical frequency in every region of the world, and understanding how much of the variance that we are seeing is related to a causative variant that are causing the disease, or just a combination of more variants together could cause a defect that actually there are ongoing studies on this later type of abnormality that I was mentioning. Next one. So approximately with all the analysis that I showed, there are 5 to 10% of the patient, they are remaining without any genetic analysis, and further analysis, especially by the next gene is necessary, like exome analysis by the families to understand if there are new genes that we are missing and they are responsible for the genetic defect of the clotting and deficiency. Next slide. So, and here is how difficult it is actually to establish a clear genotype-phenotype correlation. And that was the matter of my PhD when I started. And at the end of the story, I just came over that it's not really easy. Every single variant could have its own phenotype. And as I was just mentioning, there could be also some variability between the families. But usually we can say that the null mutation and large deletion insertion are associated with a very low or undetectable protein levels that we are looking for, and the missense mutation are more heterogeneous, and the unique mutation could cause a specific disorder and could have different bleeding symptoms in these patients. And it's very important to have more and more group in the world that they are working together, sharing the data, coming up with the understanding of the genetic abnormality in this group of patients. Next one, please. So here I think is important when I started to make the in vitro expression of the proteins and the gene abnormality, I looked for the embryonic lethality and compatibility of the survival of the mice model with the rare breeding disorder. And as you can see that embryonic lethality was not very frequent in some of the deficiency, like for factor 2 and factor 5, and some of the other factors like factor 10 has been reported, but mainly most of them, they are arriving to a neonate state, but they are not compatible with adulthood. And it's very important now in your region to look for your data and come over whether the data of animal mothers could be matched with the human ones. To my knowledge, not 100% they are matchable. However, with some of the deficiency like factor 7 and factor 10, we can see the similar result. And this type of analysis was very important in the past for me to understand more and more on the rare disorders and the role of a specific single clothing factors. Next one, please. At some point, when I finished with the Middle East analysis on the genetic, then I realized that the good quality register were in Europe, and I had to focus for understanding the correlation between the genotype and phenotype. And that was the reason I made an application for the European Commission almost years and years ago, I would say. And it was the 3 years analysis on 13 European centers from 11 countries with almost 500 patients. And we tried to make a standard language in terms of severity, asymptomatic, grade 1, which was mild deficiency, and grade 2 was spontaneous minor bleeds, or grade 3, which was spontaneous major bleeding. And based on that, the next slide was just analysis of several data together, and we came over with this type of conclusion that in fibrinogen and factor 10 and factor 13 deficiency, there was a good correlation between the level of protein in plasma and the severity of the patient. More protein was there, less bleeding was there. However, in factor 5, and especially in factor 7, this type of correlation was much weaker. And in factor 11 deficiency, there was no association at all. And that was a very important information for the clinician when they were going, for example, to do a surgery in their patient, and they didn't have any clinical history. So legally even talking, if you have a patient with factor 11 deficiency, how are you going to manage this person if he or she did not have any clinical history? So I think that piece of data started the chapter in rare breeding disorder, and then further and further analysis has been done to understand more the role of other clothing or not clothing factor that could have a role, for example, fibrinolytic activity in factor 11 deficiency. Next slide. So what about the treatment? When we end up almost with making a diagnosis, phenotype and genotype, I was just also making a lot of political activity in terms on drug company to bring their attention to produce more and more product, because we have several types of concentrate for the treatment of patients with hemophilia, but unfortunately we do not have that facility for treating a patient with rare disorder. So right now I would say we have two classes of treatment products. One is non-transfusional treatment for the minor bleeding, like antifibrinolytic amino acid, fibrin glue, hormones, and DDAVP, which unfortunately have a problem at this time, especially intranasal. I don't know how is the situation in India, but in Europe and in North America, there is a lot of problem for their availability. In terms of replacement therapy, we know that lots of patients, they are treated with FFP and cryo. However, this is not recommended in Europe because of their volume, because of the viral infection, and because we need to have a specific type of products. And we have some of the products, single factor concentrate. When that they are available, of course, you should definitely go for them. Next slide is just showing you, however, is a busy slide. It's just showing how variant different could be from one factor to the other ones. For example, factor 7 deficiency could have only few hours of half-life, and factor 13 could be almost half a month. So it's clear that the treatment of this patient, all of them more or less could be similar during the acute state, and you want to at least achieve 30 to 40% of them. But during the how can I say, not acute bleeding, but for the prevention of the bleeding, for prophylaxis, things are not easier. And next slide just is showing you who should be the patient that are good candidate for prophylaxis. Those that they have a high risk of a spontaneous bleeding, long-term disability in terms of CNS, GI, and joint bleeding, and especially if the family had other children and these children, they did have the problem. And in patients with significant bleeding history, I think you do not have to wait, and you have absolutely start to make the prophylaxis. Then, the prophylaxis, for example, for factor 13 deficiency is easy, is once every 3 weeks or once a month. But for factor 7 deficiency, you might even need to treat the patient twice a week or even daily based on the individualized historical story of the patient to decide how to treat the patient. So I would say at the end of the story, if we go for the next slide, next one, please. So you can see that is really not easy, and particularly for the management of women with menorrhagia. And for women with menorrhagia, again, is important to understand the clinical history with the gynecologist, the age of the patient, the culture of this woman. That was my main issue when I was just going around the world, collecting the data, coming to North America or Europe. The women, they are different. They have different beliefs, the marriages, the customs are different. You should talk with this woman and you have to select the best strategy adapted to the life of the patient. So where you do need to have actually the reproduction, hormonal therapy at some point should be interrupted. And in that condition, you might find, for example, to treat a patient for a few days, a month. And for those women that they did have, and they had the children and the reproductive age is not there, and there is no issue, even endometrial ablation and hysterectomy could be a choice because you give a high quality of life to these women, but not for a young woman. So I think that's something we need to work on in the future. And next slide is reporting also the management of pregnancy. That's another thing which is very weak to my opinion, and we do need to understand who are women with clothing disorder that during the pregnancy, the first 3 months, they need a prophylaxis because the implantation do need to have the product available like factor 13, like fibrinogen deficiency. And then later on, how far I have to go with prophylaxis in order not creating thrombosis. And then after the delivery, in some of these women, we have a drop of the level of the factors. I have to pay attention to them. And where there is this drop, I have to make an association with concentrate or what I have available, antifibrinolytic, or what strategy is available, but trying to prevent any massive bleeding and post-delivery bleeding or postpartum bleeding. Next slide. So there are lots of novelty, which today I do not have time to do it. If this type of seminars would be there, I would be happy in the future to talk about what are the extended and non-replacement therapy for hemophilia that really opened a new chapter of treatment. Especially for non-replacement therapy, we are not infusing the missing factor. We are downregulating the anticoagulant pathway, and we are using the small molecules to mimic the missing factor. That kind of a strategy is very interesting, like anti-TFPI or a small interference RNA, which is called fitusiran. And this is downregulating the transcription of antithrombin. And that's the reason why these patients that have a higher generation of thrombin, and they have been used for hemophilic patients with and without inhibitors, but we do not have any clinical trial in the rare disorder. And of course, gene therapy. Gene therapy with adeno-associated now is giving almost normal level of factor 8 and 9, for factor 9 for almost 10 years, and for factor 8 about 3 to 5 years. And these are the technology that in the future should be applied also for the rare disorder. But of course, you very well know that the markers of rare bleeding disorder are much weaker compared to the rare bleeding, compared to the hemophilia A and B. And that's the reason it's going to take more time and longer period of time to have the result on those. And next slide is just my last slide, and showing how rare bleeding disorder are heterogeneous. As I said, I started with rare disorder as a single disorder, but is a word over there. Every single disorder could be different. We need to have a very good lab testing, and there are some technical limitations. It's very important to have a good relationship with your lab and understanding more. As I said, novel therapies and new technologies changing the face of the treatment, and that would be the future for rare disorder too. And the new strategies are creation of the global partnership, perspective of data collection, better and more sensitive assays are very important, and also support provided by public health organizer. And that type of sensitivity is coming from you as a scientist and clinician to your government. And of course, more advanced therapies are needed for this patient. With this one, I want to thank you all, and I do apologize for the inconvenience time that we had at the beginning.
Thank you, Professor Flora, for that wonderful insight into RBDs, your lifetime work you presented to us. We enjoyed listening to you and got educated. We'll give you just a break of about 3 to 5 minutes to take your breath back and answer the quiz which we gave to the PG students in the interim period, and then come back to you for the question answer session.
Thank you.
Share my screen. Okay. So coming back to the PG students, the Sunday quiz. The quiz was related to oral azacitidine. You were given these 9 statements, which I'm not going to read again. This is the structure of azacitidine. A part of this quiz program is to educate you. So this is the structure of azacitidine. I want you to focus at this particular area where the position 5, substitution of carbon with nitrogen, is responsible to act as hypomethylating agent. So that's the final structure of azacitidine, and this nitrogen is very important. This is the DNA, those are the methyl groups, and that's the oral azacitidine blocking the methylation because of that particular structure. The data on maintenance therapy in AML with oral azacitidine was first presented in ASH last year, and then got published in New England Journal. Oral azacitidine maintenance therapy in AML, first remission. First author was our Australian colleague. He has given lecture to you already, Dr. Andrew V. So oral formulation of azacitidine was called CC486. This was not bioequivalent to the injectable azacitidine. The trial was Quasar AML 001. Who were the patients of AML included in this trial? These are patients of AML who achieved their first remission after intensive chemotherapy, age group 55 years or beyond, and who achieved complete remission with or without blood count recovery, and who were not eligible due to various reasons for transplantation as their consolidation or intensification. So that's the group that was included. Oral azacitidine, a pill containing 300 milligram versus placebo, given once daily for 2 weeks on, 2 weeks off, 4-week cycle. The primary endpoint was to look at the overall survival, and the secondary endpoint was to look at relapse-free survival as well as health-related quality of life. So that was the structure of the program: 2 weeks on, 2 weeks off, 300 milligram pill of oral azacitidine given for 2 weeks out of 4-week cycle. That's the overall survival. As you see over here, there was a difference of almost 10 months. Blue is the azacitidine, black is the placebo. Overall survival was 14.8 months in the placebo, 24.7, 2 years in the oral azacitidine maintenance group. That's relapse-free survival, less than 5 months in the placebo group, more than 10 months in the oral azacitidine group. So 472 patients were included, half in the oral azacitidine, half placebo, and this shows you the overall survival differences and the relapse-free survival. They're all highly significant figures. And when subgroup analysis was done, almost all patient host-related factors or the disease-related factor, the oral azacitidine group stood out as a better one. So any age group, any sex, any WHO AML classification, ECOG performance status, history of preceding MDS or CMML, cytogenetic risk group intermediate or poor, consolidation after induction received or not, number of consolidation cycles were 1, 2, or 3, response at randomization, whether it was complete response or with incomplete blood count recovery, and MRD status at randomization, positive or negative. All of them, the oral azacitidine stood out as an effective treatment. As far as the adverse events are concerned, both groups had grade 1 to 2 GI toxicity, which an oral compound is likely to have. Grade 3 to 4 adverse events included neutropenia in 41% of patients in the azacitidine group, 24% in the placebo group, and thrombocytopenia was equal in both the groups. The health-related quality of life was preserved in the oral azacitidine group. And that shows you the GI adverse events, various types: nausea, vomiting, diarrhea. They were all more common in the first few cycles and reduced as you continued the cycles right up to 2 years. And this is an article published from MD Anderson about management of these adverse events in patients of AML receiving oral azacitidine. And the conclusion of this study was that oral azacitidine maintenance therapy was associated with significantly longer overall and relapse-free survival than placebo in older subjects of AML who were in remission after chemotherapy. Side effects were mainly GI and neutropenia. Quality of life measures were maintained throughout the treatment. This led to FDA approval of this therapy for this group of patients. On September 1st, 2020, that is 1 year ago, FDA approved oral azacitidine for the continued treatment of adult patients with AML who achieved CR or CR with incomplete blood count recovery following intensive chemotherapy, who were not eligible for transplant. And this is oral azacitidine recommended for EU approval. This approval was recommended in April 2021, and it is awaiting confirmation by EU, which is just a question of time. So azacitidine oral pill tablet 300 milligram. That's the tablet, that's the pack available as Onureg in the market, the first maintenance therapy for AML. And that's the prescription telling you about the oral 300 milligram tablet daily with or without food, given for 14 days out of 4 weeks, and continued until there is progression of disease or unacceptable toxicity. This is phase 3 randomized placebo-controlled trial published for low risk MDS from MD Anderson and the group. And that's oral azacitidine in MDS with pre-treatment thrombocytopenia, once again from MD Anderson. In MDS patients, thrombocytopenia is a significant problem, and they showed that oral azacitidine can be used successfully without additional problem in MDS with thrombocytopenia. And that's a review article in Oncologist, oral azacitidine for treatment of MDS and AML. So out of the 9 statements that were given to you, by now you've understood that all were correct except that the drug is not yet US FDA approved for high-risk MDS or post-transplant maintenance therapy. It's only approved for the transplant-ineligible elderly AML in first remission. So the 8th statement was wrong. So you were supposed to answer 8. And following of you were correct in this order: Dr. Yoga Lakshmi, Dr. Ketan Nathani, Dr. Andre Kurnian. Of course, you answered twice with different answers. Dr. Pujitha Reddy, Dr. Tejaswini Au, Dr. Satarupa Mahopatra, and Dr. Thanuja Disanaike. So you were correct, but not the fastest finger fast. So winner, the fastest finger fast, is Dr. Virti Shah. Congratulations, Dr. Virti Shah, for winning. You have been attempting almost all the quizzes. I see your name every time, but this time you are fastest finger fast. So congratulations. Send us your contact details. We'll send you your prize. Well, thank you so much for that. And now we go to our question answer session, and we begin with Dr. Srimati Shetty.
Hi, Flora. My question is on dysfibrinogenemia. In the absence of antigen assay, do we have any diagnostic tools to confirm the diagnosis of acquired dysfibrinogenemia? Because we don't have the antigen kits to be used every time in the lab on a routine basis.
Hello, Srimati. It's nice to see you, first of all.
Same here.
And I know this is the biggest problem actually over there, because I cannot see how we can replace the antigen in terms of the quantitative of the protein, how much of the protein is there. Because definitely in the acute state, when the patient is bleeding, thrombin time or using the close acid is the method that you have to use. But for really the management of the patient in the future, the level of antigen is necessary, because with dysfibrinogenemia, I would be very careful absolutely to use the prophylaxis with the fibrinogen factors, because the risk of thrombosis would be really high.
An extension of the same question, dysfibrinogenemia can lead to both bleeding and thrombosis.
Correct.
Can we predict which dysfibrinogenemia can lead to bleeding and which one can lead to thrombosis?
That's a very good point. I thank you for bringing that, because I didn't have to come to go to so much detail. There are few gene mutations in the dysfibrinogenemia that have been associated with a higher risk of thrombosis. However, this is not absolute, as you know, because could be very heterogeneous, and not always the patient do have the same gene mutation. But at least those gene mutation that has been analyzed, for example, in your lab, if you have the facility to go first with the gene mutation instead of dosing the antigen, that might be a technique that you can use. There are 3 or 4 of them associated with the dysfibrinogenemia.
Okay, thank you.
Welcome.
Thank you, Dr. Srimati. Dr. Jasmina, can I request you to open your video? And all the questions that you put in the chat box, can you ask directly?
Yes, sir. Thank you so much. What a lovely talk, Flora. Pleasure to hear you. So this is a question which is a fallback of one of the talks I took for factor 13 deficiency on this forum itself. And one of our panelists had asked me that should all patients with the menorrhagia be then screened for factor 13 deficiency? If yes, when should that call be taken? Because mostly the clinicians would ask for a PT or an APTT or a routine coagulation screen. And a follow-up to that would be, if we want to think of recurrent abortions as a problem associated with factor 13 deficiency, then when should all of the recurrent abortions be screened? And if you say yes, is there any cutoff that 1 abortion, 2 abortions, 3 abortions? It sounds silly, but this is actually what we face in the lab very many times.
Hello again. I think for factor 13 deficiency should not be the first screen, to be honest. I think should not be the first set of data that you are doing, but gynecologists, after the evaluation of the woman for all the risk factor, and if they cannot find a correct diagnosis, then factor 13 should be measured. And that depends on where you are living. For example, I told you there was a region that I saw that almost all the families, they have some kind of factor 13 deficiency. In that region, of course, that could be the first screening. But in the general population, I don't think that should be the first thing that you are going to test. And which level is associated with what a specific type of phenotype is very difficult to say. Usually when you have more than 10% of factor 13, I would say that there is not really a big issue. For the first 3 months, I would prefer to have above 20 to 30% if it's possible for the woman, because it's a time of implantation. And for that time, you might keep an eye in these women. For the diagnosis, you asked me whether you have to use the activity or antigen. The answer is you need to use the activity, but you know very well the activity, especially for the low level, you need a blanking strategy. And the good things about factor 13 deficiency, that the quantitative deficiency is very rare. That makes easier. You can even use the antigen level. And if the antigen level is low, definitely the activity would be low. It's not correct scientifically talking, but practically talking, you can use it.
Thank you for that.
You're welcome.
Dr. Jasmina, any more question?
No, sir, not that I can think of now. Thank you.
Fine, thanks. Dr. Gina, thanks for logging. You had some difficulty. Go ahead with your questions. Gina got frozen. Okay.
No, she has to unmute.
Gina, please unmute. I think some problem still. Colonel Sanjeevan.
Hello.
Hello. Yeah. Dr. Gina, are you going to ask?
I'm sorry, I could.
Some audio problem.
We have an audio problem with you. We are not able to understand. There's an audio problem. So we will come back to you. Yes, Colonel Sanjeevan.
Dr. Flora, excellent talk. And after
Am I?
You are not audible, so you stop for a minute. We'll go.
Am I?
Yeah, you stop for some time. Sanjeevan.
Dr. Flora, my question revolves around therapeutics, especially, you have very nicely highlighted in so many of your slides about the heterogeneity, about the problem with the genotype phenotype correlation. And my problem specifically revolves around factor 7 deficiency. I have 2 patients, 2 young boys, one with less than 1%, another at 2%. The paradox is that the person with less than 1% hardly ever bleeds. And the boy who has about factor plasma levels of around 2% comes almost every week to 15 days with some kind of a bleeding, and he has to be given a shot of Novo-7. So my question is not just for factor 7, but for any other RBDs also, while trialing their prophylaxis, since plasma levels are not so predictive about the bleeding risks, has any studies on thromboelastogram, that is TEC, been validated to predict that who are the patients in whom prophylaxis may be warranted as opposed to others in whom, because you will also appreciate, especially in our country, prophylaxis for most of these RBDs not very cheap. I mean, and giving cryos every 1 or 2 months is also not a good idea.
Thank you very much. That's a very important practical question. You're right. And it's interesting what you have reported. For factor 7 deficiency and for factor 5, in my experience, there are two sets of patients. Those that they are bleeding like hemophilia and those that are bleeding like platelet type of disorders. And the reason of that is not 100% clear, but my feeling is that the role of the platelet and the receptor factor 7 in some of these patients. So in other words, we need to be able to measure the level of factor 7 also in the platelet and how is the first hemostasis. In terms of thromboelastography or thrombin generation, there is some study done, especially in the UK, in the management of the patient pre-surgery. And they did manage, for example, some of the patient with the analysis of thromboelastography and eventually the usage of the treatment in these patients, 7A. And the result was not bad. In our experience, the data are very heterogeneous. We think it's good for the research, but not yet standardized to be used for the clinical activity. In other words, I think you can use it, but I'm not sure that will help you to be sure what you are seeing is matching with your really clinical picture.
Thank you, sir. Thank you. And if time permits, I'll ask a question later on after the other panelists have finished.
All right. I'll take one question from the audience. Dr. David Chen V wants to know, patients with combined factor 5 and 8 deficiency, do they have abnormality in ceruloplasmin copper metabolism?
In which catabolism, sorry?
Copper.
I haven't seen them. I have to say I haven't looked for them. And being the pathway deficiency, I would not be surprised that they are some of the deficiency that we're going to discover. However, in a large number of the patients that we have analyzed in the Middle East area at the time of the discovery of the genes, the two genes that I showed, we haven't seen any associated alteration or disorder to factor 5 and 8.
Thank you. One more question from the audience. Dr. Disa Naike from Sri Lanka. She wants to know what is the reason for miscarriage in factor 13 deficiency and dysfibrinogenemia. Is it more often placental bleeding or thrombosis?
Is a matter of bleeding during the implantation. So as I was mentioning, the fetus to get infiltrated in the uterus and the formation of the trophoblast needs a sufficient amount to have a good hemostasis over there. And if the level of factor 13 and fibrinogen is low, this implantation is failed and is causing the bleeding, and this bleeding is associated with abortion. So it's an early miscarriage.
Thank you. Dr. Alim Jan.
Hi, ma'am. Thanks for an excellent talk.
Thank you.
I have two questions. The first one is that now that there is a genuine understanding and acknowledgement of rare bleeding disorders, are we in 2021 somewhere close to some kind of an algorithm to diagnose and possibly predict and gauge clinical severity? This is from a clinician point of view, because we now know that these diseases are autosomal recessive and we do maybe having a good number of cases. Do we have some kind of an algorithm where I should suspect and apply that? Thanks.
You know, being autosomal recessive, you know how is the transmission. So that means if you have two parents that they are heterozygous, in 1/4 of the children, independently if they are male or female, they could be affected. And you could have 50% that they are heterozygous and 25% they are completely normal. This is the regular things of autosomal recessive. But the main issue here is not this algorithm, is the problem of the penetrance. The allele variant not always has the same penetrance, as we were just discussing, the case that Sanjeevan was explaining about factor 7 deficiency, that was a mutation associated with complete absence of factor 7 in plasma. However, the patient did not have a severe bleeding. So the most difficult part for understanding the correlation between the genotype and phenotype is how we are calculating the allele penetrance for each single type of gene mutation. So that's the reason I would say for the null and big deletion, we can say this is associated with almost a high penetrance. But for those that they are associated with the missense, really is very difficult to understand. But what you can say just to your patient, do not get married, inter-family marriage should be stopped in where the rare disorder is frequent.
Okay, thank you very much. Sir, can I ask another question?
Of course.
Now that you said that we have some data from Middle East where there is consanguinity, and there is a project going on ProRBD, so which is an European network for such disorders. So it's worthwhile to broaden the database of that project to include those.
You're right, Alim, because I was working for this project, as I said, from 95 to 2007 when this project we had a funding from the European Commission. And then European Commission stopped to support the big register because they said, okay, once they can, you need the funding for that. Now, the format of this database is available. I mean, when we want, that's available and we can use it. And there are lots of people around the world are in communication with us. We help them to make the diagnosis, genetic diagnosis, and we can use it. But of course, we need the support. Support could be governative support or pharmaceutical support, but that kind of things we have to work together.
Thank you very much. Thanks.
Thanks, Dr. Ali. One more question from the audience. Dr. Mendis from Sri Lanka wants to know that there is a young lady with factor 7 deficiency with significant bleeding history. Now, in a resource-poor country, what kind of prophylaxis can you offer?
In a woman with severe bleeding, if it's menorrhagia, I think antifibrinolytic is the one that you should use, and pills, and trying to program very well the reproductive age of this patient. And if this is a girl and does not need the pregnancy right now, and I think hormonal therapy, that's what I think is important. Unfortunately, a portion, about 20 to 30% in my experience, they could have hemarthrosis. And that's the terrible part. You do need to have factor 7, plasma-derived or recombinant factor 7. And there is no other way. I mean, of course, I'm just thinking about the cryoprecipitate, but the amount is very low. And I think the only things I can think for the treatment over there is the concentrate.
Thank you. There is a connected question from Dr. Arihant Jain. For a menorrhagia, how do you decide whether to use estrogen progesterone pill, whether to use pure progesterone pill, whether to use androgen, or whether to use hormone secreting intrauterine device?
I think that part is not your choice. You should talk with your gynecologist. This is what we do. And also because the safety and the generation of this product, they are coming, they're changing, and there are novel and novel therapies are coming. What I do in Milan, I think I have not enough really knowledge to know what type of hormone I have to use. And I have a clinic with our gynecologist once a week, talking and deciding together what we have to do.
Thank you. Dr. Gina had an audio problem, so she has messaged. Her question is that she has a patient as a child, was diagnosed to have factor 10 deficiency, had intracranial hemorrhage at the age of 1 month. Now this child is 12 years old. The phenotype is very severe, and she's treating him with FFP on demand. What will be the best way out?
Definitely this child needs the prophylaxis, and you have to do it before having the second hemorrhage. The best way of treatment to use the single factor 10 product, which is now available from BPL, I think. I don't know if that is available everywhere. The second product is a product from CSL Behring, and that's contain factor 9 and 10. And third product is the complex of prothrombin, which is including factor 7, 9, and 10. However, you're introducing also other factors. How much you have to do it? I think you need to treat him at least once a week with 20, 30 unit per kg in order to prevent the bleeding.
Thank you. One more question from the audience. Young married woman, 4 times miscarriage in the first trimester. Out of the RBDs, which will be the commonest cause?
Yeah, in this case, definitely, if all other causes has been looked for it, I think factor 13 and fibrinogen level should be measured. And in my experience, I always say this story. I seen a very 39 years woman with 13 abortions, and she came to my attention, and that was in Middle East area again. And of course, her life was destroyed for every point of view. And simply, we looked on it, and it was severe factor 13 deficiency with not other signs and symptoms, and only menorrhagia, and that was present. Of course, she was underestimating that. And we started the prophylaxis, and she started to have a regular life and pregnancy. And I never forget this experience in my life. So I think this woman, please do measure fibrinogen and factor 13.
Thank you. Professor Chandrakala.
Thank you, Dr. Flora, for such a nice talk. Continuation with Dr. Gina's question. We recently was referred a young male with the factor 10 deficiency, severe phenotype for the knee replacement, total knee replacement. So in India, we don't have a PCC, we don't have factor 10. We have APCC, we have plasma. So he was not able to walk, he had a severe pain. So we had to post him for surgery, knee replacement. So with only plasma, cryo, and APCC, how should we go about it?
You can use APCC is the best choice, I would say. And you can treat about 20, 30 unit per kg once a week. And if that's enough, you can see it. If it's not enough, could be increased to twice, but I think it's difficult to find that amount of product. I would propose at least once a week. If that's not available, cryo. Each bag for 10 kilo of your patients.
Yeah, we use the APCC in our patient. Today is day 15 of his surgery. We had to use little bit higher dose because to maintain the level of 80%. So till now and day 15 is doing better. Initially, we used twice a day, and the day second, we used once a day, low dose, 20 units per kg. He has undergone knee replacement. So he has never bled actually. His levels were around 80%.
Oh yeah, during the acute, I fully agree with you. You need
replacement.
A higher, yes.
Yeah.
Oh, the replacement, you need to keep the level much higher. I'm fully agree with your schedule. But yeah, after that, to prevent the bleeding, I think the lower amount could be enough because you don't want the accumulation of other factors and the risk of thrombosis there.
And then recently we had one more patient referred with factor 13 deficiency with the psoas hematoma, massive psoas hematoma, factor 13 deficiency. When we did a factor 30, we gave a cryo. We don't have factor 13. Actually, we have, but it's not affordable for us. So we gave a cryo. He was not responding. When we did for the inhibitors, it turned up a factor 13 inhibitors. So the bleeding was continuous. So how should we manage? The young chap, he continuously bled in the stomach. It was like abdominal distension. So how should we manage such patients?
That's a very difficult case. Actually, it is very strange because the number of the inhibitors in the world for factor 13 plasma-derived product is extremely low. Is it an autoimmune disorder? Because usually these cases are not congenital and are acquired, associated with lymphoproliferative. Is it congenital cause?
The congenital cause is a symptomatic from childhood. He had actually had received about 25 exposures till his lifetime when he presented to us. So that was it's a congenital factor 13 deficiency.
You know, in the case of acquired one, what we do is a plasmapheresis to get rid of the antibodies and any kind of immunosuppressive therapy that you have. We do not have so much experience because even factor 7A is not enough because you don't need the clotting. You have to stabilize the clotting with, I would use the antifibrinolytic, plasmapheresis, and eventually rituximab.
Yeah, just to share our experience, we did not use the plasmapheresis because hemoglobin did not increase more than 3 to 4 grams. So that's why we could not use. We could take rituximab and antifibrinotics we used. We gave actually Novoseven also. We could not salvage the patient actually. So that was he could.
Not even rituximab.
Not even rituximab we responded. We gave rituximab actually. So that was a very, very difficult case. We have seen only one case. So that was difficult to manage.
In my entire experience, I never see the case. I think you
Thank
should publish this data, please, because that's a very important. However, as you mentioned, we can, I don't know really how we can do it, but the only things I can imagine is a, you know, immunosuppressive treatment if you have enough time, because you need 10 days or 2 weeks to make it work. And also understanding a little, do you have the gene mutation of this patient?
Oh, actually, we could not get. We have sent the sample. Actually, we have a sample of the patient, so we are waiting for that. Actually, we'll see.
Okay.
We are waiting for that. Yeah.
Interesting data. I'm sorry for the patient.
Thank you very much. Thank you. Thank you.
Thank you, Professor Chandrakala. One more question from the audience. Dr. Peyvandi wants to know, we get a lot of references for investigating epistaxis and menorrhagia. The workload becomes huge. If there are no other clues to the bleeding disorder, should you still investigate them? Pure epistaxis, pure menorrhagia.
Yeah, I mean, as I said, the mucosal type of bleeding is the most frequent sign and symptoms. And especially in factor 7 deficiency, I saw a lots of epistaxis. And that could be, it's difficult to understand the causality. We know that in mucosal type is important, these factors. But what is important to understand that these people do not have a good treatment, oral health situation, because they are afraid of bleeding and they are not treating themselves, the gingival, you know, cleaning or things like that, or because really they have the gingival bleeding because of factor 7 deficiency or other type. So I think for those that you have assured that everything that should be done on the gingival health has been done, but still the bleeding is there, you can investigate definitely for any kind of rare disorder, no doubt.
Right. Dr. Sumit Mirg wants to know, while replacing factor 13, what is the drug level that you will like to maintain as a prophylactic therapy?
For acute bleeding, definitely more than 30%. For the prophylaxis, more than 10%.
Thank you. Dr. Vijay Kumar Pillai wants to know, in factor 7 deficiency with inhibitor, what are your guidelines for management?
That's another good point. You have to check that this inhibitor is also against factor 7A or is not. If it's not against the factor 7A and is against the plasmatic factor 7 zymogen, you might use factor 7A. Otherwise, you can use FABA.
Thank you. Dr. Karim wants to know, what is the status of gene therapy for factor 13 deficiency?
I think we are far away. There is only a little bit about factor 7 deficiency that has been done in the UCL by Professor Ted Tadaram and Amit Natwani. And we tried to make application for the European Commission, but we were not supported for that, and things have been stopped over there. So I don't think any gene therapy right now is available, not scientifically, because scientifically that adeno-associated vectors could work very well with factor 7, with factor 10, but is not ready in order to be used for the patients.
Thank you. He also wants to know, what is the latest treatment of factor 13 deficiency?
Recombinant factor 13, every 3 weeks, and in pregnancy every 2 weeks, by 20 to 30 international units per kg.
Dr. Radha Jayatunge wants to know, there is a lady with factor 11 deficiency and she had CNS bleeding at the age of 23. Now on, what will be her prophylaxis?
CNS bleeding is not usually associated with factor 11 deficiency. My advice would be, do not stop with factor 11 and make sure that this patient doesn't have any other type of rare disorder too, because the prolongation of APTT could be associated also to other type of factor deficiency that you are missing, and the cause is not only factor 11. For factor 11, really the level is not indicative for what is happening. So what you have to do, I'd be very, very cautious to give the prophylaxis with concentrate of factor 11 because it's very much thrombogenic and usually is not used. And I think antifibrinolytic, that is what I use.
Thank you. Dr. Satish, your question.
Thank you very much, sir. Thank you very much, Professor Flora, for enlightening such a difficult and a rare topic. I had a 47-year-old female who has chronic calcific pancreatitis and was planned for a major surgery, phrase surgery, and incidentally detected to have PT-APTT prolongation. On further evaluation, she had both factor 5 and 8 deficiency. Factor 8 was 12%, factor 5 was 9%. On taking the history, very surprisingly, she has undergone major surgeries. She has undergone a cesarean section. She has donated the kidney for her husband. She has undergone nephrectomy, and she says she never had any bleeding issues. We are really surprised, but definitely we confirmed the factor 5 and 8 level from a different lab, and they were both low. So how do we manage for a major surgery factor 5 and 8 deficiency? My first question, because we have factor 8 recombinant and plasma-derived products, but factor 5, unfortunately, the only source is FFP. Second question in the same case is, can we see acquired factor 5 and 8 disorders without any inhibitor? Can it develop later in life?
A very interesting case, and usually they are not very severe bleeders, but not as low as you are mentioning. I never seen with this level such a picture of not bleeding during the major surgery. This is really strange, and I think you need to understand the generation of thrombin of this patient and understand what is the level, for example, if it's homozygous for factor 5 laden or for other type of the risk factor for thrombophilia. I would do that. And I think for the treatment from legal point of view, however, she's not bleeding, but you cannot really leave her with 9% or go to do the major surgery. So for that, for factor 8, you have to treat this patient with about 40 to 50 international units per cage for the major surgery. And also DDAVP if is not a emergency type of treatment, and you can make a 1 hour and 4 hour response to DDAVP and understanding how is the response. For factor 5 deficiency, what you have to do is using the plasma and FFP. That's the only source of the product that you have and you can use. In terms of acquired factor 5 and 8 deficiency, to be very honest, I never saw it. And it would be very strange that you have an antibody that, because factor 5 and 8 are normal in these patients in terms of synthesis, as I said, they are not secreting. So that means you should have something against the protein of MCFT2 or the ERGIC that I never seen in my life. But this case is very interesting. I would be very happy to study that.
Okay, ma'am. Sure, ma'am. I will encourage her to do some studies. And we did give plasma and factor 8. Somehow we could carry on the surgery. She did have some post-op bleeding. The PT was quite prolonged, so we had to give more FFP. Factor 8 was easily available, but giving FFP was a challenge. But fortunately, she went through the surgery and she's doing fine now. Ma'am, the second question I have is in factor 13 deficiency who are only cryoprophylaxis and because of financial reasons, when they become pregnant, can we just increase the frequency to once in 2 weeks for the first 3 months and then go to a regular prophylaxis?
Absolutely, yes. That's the way you have to do.
Okay. Thank you, ma'am. Thank you so much.
Thank you, Satish. Dr. Gunjan.
Thank you, ma'am, for a very informative talk. My question is about the role of the newer factor 7A recombinant factors like Merseptacog alpha in the management of these rare bleeding disorders and anti-TFPI antibodies like Merseptacimab. Is there any good data about this in rare bleeding disorder?
In rare bleeding disorder, the only data that is available is about fitusiran, which is lowering the transcription of antithrombin in the liver side. And this product, as you know, has been used in hemophilia A and B with and without inhibitors. And in vitro, they looked on the plasma of the patient with other type of rare disorder, but never have been used in any patient, any kind of non-replacement therapy. Would be interesting in the future to have them. And also the product of factor 7 with a longer half-life, which is interesting, never have been used in this type of patient with factor 7 deficiency.
Thank you, ma'am.
Thank you, Dr. Gunjan. We'll take a couple of questions from the audience. In a case of significant thrombocytopenia, how do you do the platelet function studies?
Oh, I did not touch the platelet studies here, but I think the first thing that you want to look is the secretion and the aggregation at the first step, and then there are several types of the studies, but I think this is the first two analysis that you want to do, aggregation and the secretion of the granules.
Yeah, his problem is that the patient's platelet count is very low.
Oh, how are you going to do it? You can do it. You need at least to have 50,000 of the platelet or even more. If especially you are using the standard aggregometer, it's going to be very tough to use these techniques. So always we have this discussion with our labs. They make the condensation, but I think the assays are not really good for it. PF 100, but even there, I think less than 50,000 is not really suitable.
Dr. Karim wants to know if there is a patient with multi-site bleeding and all your lab tests come negative, how do you explain?
We have a few families like that. What you should do, you have first of all to understand really if this bleeding is there, present from when the patient was a kid, so is acquired or is congenital, the history of the patient. Family history to understand whether there is more members of the family, they are having the same thing. If you have a good family with at least 2 affected and few unaffected, with clear picture of bleeding, now you have availability to use the next gene analysis. I think you can call Shirmati, she knows how to do it. And then you can look for the first exome analysis to look for other genes that could be responsible with a good bioinformatic analysis to come up with the new genes. That's a strategy that now is ongoing.
Thank you. Dr. Arihan Jain wants to know if there is a GI bleeding in a patient who has a bleeding disorder, should you always do scopy to rule out additional local factor?
Always, almost, even in von Willebrand patients where the GI is getting more frequent, and with the age, the GI getting more frequent, you should definitely ask the drugs that this patient they are having, and you have to exclude any other type, ulcer or cancer or any type of the problem, polyps that could be associated. But again, if you have a patient with a recurrent GI and you already did everything last month and you did not find, you make a gastroscopy, colonoscopy, and all of them, they were negative. And 1 week later, the patient is coming and having the same symptom, I don't think you should repeat it again. You can repeat it if you are using the local hemostasis strategy to stop the bleeding. Otherwise, it's useless. And you know that the patient could have angiodysplasia or another type. So you have to make a good hemostasis over there.
Thank you. Dr. Srimati, your question.
Yeah, I mean, Flora, we do a lot of antenatal diagnosis. I mean, we might have done around 3,000 families for hemophilia. We have extended for rare bleeding disorders too. My question to you is, in one of the slides, you said that even within the family, the severity may be different. So my counseling to the family, I mean, am I ethically right in doing the antenatal diagnosis at all, or the counseling, what kind of counseling we have to do to the families?
Ethically, this question is very difficult, Shermati. Depends on where you are living, in which region of the world, and what is available. Usually in Europe, we say that should be limited for really severe cases where the clinical history is very severe and there is already one affected child. Okay, that's a strategy we use. However, when I went through developing world and developed world to look on the abortion request of the women, you could see that the request of abortion in the developing world is much higher because there is no facility for treat the children. So I think it's very important to talk with the family and understanding, first of all, understanding whether that gene you're sure is causing a severe disorder. Because if it's a mild disorder, you do not have to do it. If it's creating the severe disorder, then again, I think you should discuss it very clear, as you know very well, after all this experience with hemophilia, what could be the heterogeneity over there, and still if they think they have no facility to keep another child with the affected situation, I think you should help them. That's my strategy, and there is not a specific guideline on that, and it's very different from one place to the other place of the world.
Okay, thank you.
Thank you, Dr. Sanjeevan.
Yes, a small trivia question. Actually, Dr. Flora's one of the slides got interesting. I got interested in that when she was showing the mouse model. Now, in that, I noticed that out of the mouse models, the factor 7 deficient mice all had embryonic deaths, versus, as well as they did not survive to adulthood. It's the exact opposite in humans. It's the commonest RBD. And we see a large number of factor 7 people, I mean, hardly any abortions, hardly any people having a major bleeding. So is it something to say that the mouse model and human models are not really congruous?
This is the biggest question that I could not respond in my life. I tell you why. Because when I saw this data, I'm glad you're bringing it out and you looked very carefully on the table, because usually the people don't. And we have not, when I was in London doing my PhD, we found a child from, I think it was from Singapore. And he had one mutation, which was 2 single nucleotide deletion at the propeptide site of the factor. That means knocking out the protein. And this child was alive. And this was not compatible with what we've seen in the mice model and usually is reported. There was a lot of discussion. That paper has been accepted by the JTH at that time, actually TH at that time, but there was a lot of discussion with the scientists, which was complaining and to saying maybe there was some other gene mutation in the bottom part that was correcting this deficiency which was there. And I never could show that. So making a long story short, I really do not know that we have that kind of 7 deficiency with completely knocking protein that they are surviving. Even in human, the level are low, less than 1%, but you need only few picomole of factor 7 to activate the clotting system. And that pico, you cannot find it with any assay in the hemostasis. You cannot use it PT assay one stage to measure that. So that's the reason you need really to make the analysis of the genome and to make sure that factor 7 is completely gone. And we have no data on that.
Okay, ma'am. Maybe you've done so much of thoughts into this. I was just in the last half an hour thinking that, I mean, Dr. Srimati may be the more appropriate person to answer, that when you are doing mice model, you are using only one kind of intervention. You're knocking out the gene. So, all your mice model have only one kind of defect. Whereas in humans, it is out of selection. We don't even know how many of such knockout genes would never actually even get born for us to be able to analyze them. What human beings are born are the ones who have gone through all these phases. And maybe they have some other missense mutation, which is not as severe as the ones in which in mice model you are knocking them off.
I fully agree with you. And that's the reason why the small animal model are not reflecting exactly what is happening. And more bigger becoming the model is more closing to human. And even baboons are not reflecting exactly the same situation. I fully agree with you. That's only a start point, but not necessarily means is translating what is happening in the human body.
Thank you, Sanjeevan. Dr. Arihant has another question. To look for the rare bleeding disorders in lab, what should be the minimum interval after plasma products have been administered?
As a diagnosis or as a treatment? As a treatment.
As a not mentioned here, yeah.
So for the diagnosis, at least you have to have PT, APTT, and TT at least to do that. And factor 13 in somehow you have to measure it. For the treatment, at least you have to have FFP and cryo.
Yeah, and the question is, if a patient has received plasma products and now the lab has been asked to investigate the child.
Oh,
how many days to wait?
Oh, okay. So it depends of the type of the deficiency, because if the patient has the factor 7 deficiency, usually you do need to have 5-6 times multiplicate on the half-life of the factors, and you have to wait. For example, for factor 7 deficiency, if it's treated even a day before is enough, the day after the measurement. But for factor 13, if the half-life is 15 days, then you need really to wait much more and is contaminated with the exogenous factor that you have introduced.
Sure. Dr. Visakha wants to know, she has a patient where the clot solubility test is positive, but she did factor 13 assay, it came normal. What could be the discrepancy due to?
That's very strange. I think something did not work, because the clot solubility is associated with a very severe deficiency. That means the level should be less than 10%. I think your assay, one of the two assays did not work properly.
Right. Dr. Islam wants to know the best management for factor 5 deficiency.
Unfortunately, there is no best management. It's only one type of product, actually two. Is a plasma product, I mean FFP, and 15-20 ml per kg is the amount that you need. 10-15 also sometimes depends. In the acute bleeding is difficult to jump with the level of factor with only plasma, but that's the only source of the product that you have. And if that is a issue because the patient doesn't respond, sometimes you might want to use also the platelet infusion, but you have to pay attention because you don't want to have the autoimmunity against the platelet.
The last question in the question box is from Dr. Samar Veera. COVID patients get thrombosis. Have you seen severe bleeding in COVID patients?
Yes. We did a lot. So my center, actually my department is an internal medicine department. We had almost 20,000 COVID patients in the first and second wave that went through our hospital, which is a hub center. In the first COVID wave, we were introducing the high rate of heparin and did work really very well because we were having about 30% of thrombosis, deep venous thrombosis and pulmonary emboli when we did not know what was happening at the beginning of the COVID. So that introduction saved a lot of our patients. But in the second wave, this type of a strategy was associated with a severe bleeding like hematorosis, hematoma, not hematorosis, big hematoma, and sometimes we had also the GI bleeding. The reason of that, I think, because we were managing much better the inflammation in the second wave. And having less inflammation was not necessary to have that amount of heparin that we were using in the first wave. So I think you should be very, very careful when interpreting the data of the several places, different condition, clinical condition, different waves, what type of anti-inflammatory product has been used. So I think now for what is the state of the art in terms of the steroid usage or monoclonal antibodies, I think low prophylaxis with heparin is enough.
Thank you, Dr. Chandrakala.
Thank you, sir. Dr. Flora, we have few patients of VWD who are pregnant during pregnancy. Which patient should receive prophylaxis during pregnancy? And if most of them has 1.2, 1.3, all I'm talking about type 3 patients. Okay. And what should be our strategy regarding the postpartum and the spinal anesthesia should we recommend? If we give spinal anesthesia, how long we should give factors?
For von Willebrand, especially type 3, I think you need the prophylaxis and you need at least once a week or twice a week. And the level of von Willebrand, I would prefer not go lower than 30%. For depends on gene mutation of this patient. And some of the severe cases like type 3 might not be really with less than 1% and could be some factor 8 over there also. So that's very important to know what is a minimum level, but I would prefer to have between 20 to 30%, not lower than that. And you know that if there is no null mutation or big mutation, might be a little bit of increase of the levels. And that's needs to be evaluated too. For the spinal infusion, I think is very important to have at least 50% of the factors. And there is a new guideline of the ISTH World Federation and ASHI, not actually, ISTH World Federation, showing that the level should be 50%. Post-delivery, for at least few days, you need to make sure that the level are not dropping lower than 20, 30%.
When should we start prophylaxis for toilet giving? What time is
prophylaxis? So if you type
when should we start prophylaxis in pregnancy?
I would start as soon as possible. Because again, it's a matter of abortion. You have to be careful that they are not having the abortion. So I would start in the first period of the first trimester, and then maybe during the second trimester you be a little bit more relaxed, but then during the delivery you have again to start the prophylaxis.
Okay, we have never used in our patients actually, but we have around 5-6 patients who has delivered. See, the whole points are actually one more minute I'll take. See, hemophilia, we maintain the factor 8 level more than 1% in the prophylaxis. They already have 1.1, 1.5, 1.8%. So what is the reason we should give prophylaxis? 30% maintaining, is it necessary during pregnancy? That is such a high.
Okay, first of all, even for hemophilia, now, you know, the guidelines, European guidelines are talking about 5% at least. The level of factors for the rare disorder von Willebrand and hemophilia are not similar in my experience. You can have much higher level of factor in factor 10, but they could have the bleeding. So 1% is not enough. And I remember we published a paper where it was showing that 1% of each single type of factor are not giving the same generation of thrombin. So you might really need a different level of factor. So that's the reason in my experience for the rare disorder, I saw that 10% is important for spontaneous bleeding. For not spontaneous trauma related, I can really see that 20-30% is really a level that are at least starting with 20-30, you know what I mean? Because you cannot keep it always 30%, that's impossible. But starting from that point, that means you are reaching about 4-5%, and that's a level that you don't want to go lower than that.
Thank you, thank you, thank you.
You're welcome.
Thank you. We have no more question in the question box. Faculty here, you have anything, Bernie? Nothing at all. So I think, ma'am, thank you very much for educating us. We'd like to bother you after 6 months, if you permit.
Sure. This time we can talk about hemophilia.
We do that. That's so common and that's so important for everybody.
Yeah.
Paresh will give the official vote of thanks. Paresh.
Thank you.
Paresh, are you there?
Yes, sir, I'm there. Thank you. Thank you on behalf of Pharmafer. I would like to thank you, Dr. Flora Peyvandi, for sharing your valuable knowledge towards this subject. Also, thank you very much to all the eminent faculties who were present here and also all the distinguished delegates who were present for this meeting. Thank you, Professor Dr. B Agarwal, for arranging once again a very good academic quiz today. And thank you very much that Pharmafer. It is very proud for us that Pharmafer was part of this meeting. Thank you very much. Thank you to all.
Thank you very much for the invitation. It was really a great pleasure to see all the friends. And as I said, I hope to see you soon face to face. Take care. Best wishes.
Bye.
Thank you, ma'am.
Bye-bye.